Hi, I'm Donna Olson, the Administrator for Interim Healthcare, the Gift of Hospice here in San Diego County. This presentation is number one in a series of presentations being prepared for our staff in hopes of helping you feel very comfortable with the knowledge you already have and apply every day in getting ready for our CHAP survey. You have been provided an interview guide. This particular presentation starts on page 18 of that interview guide, and it is the third set down where staff begins, and this is a series of core regulations, which is why the C is where we start. So it's core section 1.3C we start with. Personnel understand and use the organizational structure as outlined in the organizational chart. Now again, this particular section is specifically for you, the employee, to have knowledge of, be able to demonstrate, and be able to answer these questions in interview. There's another series of videos that we made that are specifically related to what the patient and family will be asked. So if you've already watched those, that's fabulous. When you watch this series, know that these are the very questions that you, the employee, are going to be asked. So it's my hope that this will help you feel really comfortable about your answers. So this particular regulation is asking that staff members are familiar with the organizational chart and they're able to state their individual lines of authority and accountability, all right? Including the office employees and how they're oriented. Not long ago, we updated our org chart, and all of you received an updated copy because we were happy, I was thrilled, to finally get a director and a quality assessment nurse, so I took those two hats off. So not long ago you did receive an updated org chart. Org chart is an organizational chart, which does delineate the lines of authority, and the organizational chart is kept in the policy and procedure manual, but it clearly indicates who supervises who and who's in charge of who. There are two forms in the policy manual. One is a list by title, and the second is a list that has the names of all the people in those titles. So what a surveyor is going to ask is, how do you know who to report a complaint to? And your answer is, oh, that's easy, I just have to know my org chart. You don't even have to say that answer, you guys. You're going to say who your supervisor is. And then they're going to say, well, how do you know that's the person? They're looking for you to know what an org chart is. They're looking for you to know that you were shown in orientation and that we have continued to update the organizational chart every time a new employee comes on board. The next section, the next reg, which is core 1.5i, staff members have access to policies and procedures and they can describe the process for getting them. We have 3 policy and procedure manuals in the offices that are specifically related to just the delivery of hospice care. Jody, the director, has one. Alicia, the quality assessment coordinator, has one. And I, your administrator, have one. All 3 of us have the large policy and procedure manual. This particular manual has all of the guidelines and principles for how we determine if a patient meets criteria, what documentation is required to sign them on, ongoing care, what changes or symptomatology has to present for them to move to a different level of care, of which there are 4 levels. What isn't in this policy and procedure manual are other policies that guide our care, specifically nursing-related policies and procedures. For instance, this manual doesn't tell you how to put a Foley catheter in a patient. It doesn't tell you the policy for changing a dressing. It doesn't tell you the policy for flushing an IV line. You need a clinical manual for that, and we use the most current edition of the world's respected Lippincott Manual of Nursing Practice for that. So the policy and procedure manual is available in my office, in Alicia's office, in Jody's office. The clinical manual is available in Alicia's office. She's your QA nurse and she's your expert at what's quality care. So that's where that one is. There are two more manuals that some of you are interested in and use. One is the Business Operations Manual, which has all of the information about the bereavement program, our spiritual care, the volunteer program, and a whole lot of stuff about me as an administrator maintaining a viable business. So only a few of you will really use much of what's in here, but it is in fact a policy and procedure manual that guides our care. And we have a human resources manual that has the policies for recruitment, hiring, advertising, job promotion, job descriptions, administering your benefits, etc. So we have a series of policy and procedure manuals that guide our care and keep us compliant with not just Medicare regulations, but also the CHAP regulations. So the surveyor is asking you to be aware that you have policy and procedure manuals. You don't have to know the answer to every policy. You don't have to know the content for every procedure, but you do have to be able to tell them where you go to find out what it is. And you definitely need to know the policy before you conduct the behavior. Okay? C 1.5, 6.6a, sorry. Language-specific written materials as necessary and appropriate are available for distribution to client and families. They're looking for staff members to demonstrate that you're aware and that when you need to, you use resources and materials that clients and families need to know, and that they're language specific. You know, because you're already giving out Spanish speaking things every day, you guys, but you know, we have the When the Time Comes booklet in Spanish, we have the 3-page consent in Spanish, and we have available to us multiple languages. I refer to Spanish because that is what most of our non-English speaking families have been, but we have the ability to get any language materials that are required. We also have the language line, and recently I did provide to all of you an updated chart that has the language line numbers, that has the phone numbers for our Spanish-speaking staff, as well as the home health organizations, which have multilingual available staff to us during regular hours. The next one, which is C 1.7b, is that the policies and procedures outline responsibilities of the group and the process for submitting ethical concerns and issues for action. So this particular regulation is specifically about what do you do if you have an ethical concern or issue. So first let's just decide what is an ethical concern or issue. Well, there are tons of examples that we actually deal with all the time in our IDG meetings. A family member who wants their mother to be a do resuscitate. Another family who wants their mother to be a do not resuscitate. Well, from an ethical standpoint, what do we as a team do with that? Well, there are laws that guide us and documents to have in place to determine what we have to do legally. That doesn't take away the feeling that we might have that is that the ethically correct thing to do? When we have a 102-year-old woman who didn't put in writing what her wishes were, and a daughter who wants us to do everything possible to save her, including jumping on her chest and breaking ribs and having her end up on a ventilator. What's our ethical position? What do we do? So we have an ethics advisory committee. The surveyor wants to know that you know that. The surveyor wants you to say, well, when we have an ethical challenge, we talk about it. All the people on that particular case talk about it. It's part of the Comprehensive Plan of Care, or CPOC, that we talk about it with the family or the caregivers or whoever's involved. And if we can't come to a comfortable decision process, if we just feel like we need something beyond us, we have a policy for our ethics advisory committee where we can bring in experts based on whatever the ethical dilemma is and consult them to make a decision. So the surveyor just wants to know that you know we are faced with ethical challenges. We have an ethics committee to help us make the right decisions, and we can employ the use of the committee for making those decisions at any time we need to. The next one is C1.8E, new knowledge from internal and external research is integrated into practice as applicable. So what they're asking for you to be able to recognize is that that old adage, we've always done it that way, doesn't apply. We're in a dynamic field. Medicines are changing, treatments are changing. The way we look at our care of patients have changed, it continues to change. So same old status quo doesn't work. Surveyors want to know that the application of our care today is the best possible based on research and statistics and what's called best practice evidence. So how do we do that? You guys know. We have in-service education on a regular basis. You are constantly getting articles, updated regulatory things. We have resources all around us in the form of journals that teach us and present to us what the latest information is and what research clinical studies have been shown. We use the Journal of Hospice and Palliative Nursing. We have Practical Pain Management. There are a multitude of industry-specific email newsletters that we get, and we talk about what we're seeing now in the hospital, what other hospices are doing. We benchmark what we're doing. We have other magazines for the nurses, in particular nurse.com. We have specific home health aid magazine to keep the home health aides current. So what the surveyor wants to hear from you is that we're applying best practice evidence-based care so that we're doing the best thing we know to do in all circumstances for hospice patients today based on what research is out there and available. One more, C2.2B, collaboration and networking with other providers, enhanced provision of care and services as applicable. Hi, I'm Donna Olson, the administrator with Interim Healthcare, the Gift of Hospice in San Diego County. This is number 2 in a series of presentations we're preparing in hopes of helping my employees, you, feel more comfortable with surveyors. There isn't anything new in these presentations, just a review and something that I hope will give you some guidance and peace of mind. I know how ready you all are, what a great job you do every day. So we're going to start the second in this particular series, which addresses questions and information that the surveyor will be specifically asking you, the staff, to have knowledge of and be able to demonstrate. We're on page 18 of the CHAP Hospice Interview Guide that you've been given. And we're near the bottom and the next to the last one, which is a core regulation, C2.2B. Collaboration and networking with other providers, enhance provision of care and services as applicable. They're looking for you to be able to tell them that the professional staff, the technical staff, and any support staff, all of those people are able to tell how we coordinate and collaborate so that the patient receives the best kind of care, and that is also true for those employees that are on contract, not just employees that are actually a direct employee for Interim Healthcare, the Gift of Hospice, but those we contract with. So on your telephone rosters, you know that we have a section of our contracted providers. And the surveyor will expect you to be able to say, well, when the surveyor asks you, how about your therapist? I see on your roster that they're under contract. How do your therapists know what the plan of care is. How do they get the updates? And it's the same answer that you give the surveyor when you talk about how a social worker would know what the plan is, or an aide would know what the plan is. The nurse case manager stays in close contact with all disciplines on a case, and when there are changes, actually calls and has the conversation, and that information is applied to the interdisciplinary group updated comprehensive plan of care, or CPOC. So in addition to the therapist as contracted providers or contracted employees, the DME company, durable medical equipment, and the pharmacy, ACP, Advanced Care Pharmacy, those services are provided by contract. The ambulance company that we use to transport our patients either to the hospital or to do those things on the bucket list that we enjoy doing, whether that's Max Care Ambulance or TLC, they're contracted providers. So they're on the phone list identified that way, and we have contracts with them, we have copies of their insurances, and they are collaborating with us for the best care of the patient. And they get the updated information by us reporting to them what the changes are and what the needs are of the patient. The next regulation, C2.2C, supervisory and clinical or service staff demonstrate knowledge of organizational policy and procedure for ensuring delivery of care, services, and products to clients. And specifically, you see in the next column, that you're able to describe the on-call system for after hours when our organization's office is closed. So, you know, when we do the start of care, when the nurse goes out and admits the patient, part of what's in the patient and family information packet is a description of after hours coverage that says we have a nurse on call 24/7. It's the same office number you would call during the day, and that we're always available for them. We also post a red piece of paper from that manual that says do not call 911, that tells them again for anything they need, we're always available at that same number. So when the surveyor says to you, well, how do your patients know what to do if it's after hours? You know the answer, you guys. They know. Not only are they told from the beginning that we're available 24/7 no matter what, and we want them to call us, they have in their house every piece of information with the same exact phone number on it. It's not a triage system, it's our registered nurse who answers. That's the answer for the surveyor. And you know yourselves, every one of you, remind your patients when you leave to call us and not 911. So you see that number on the red notebook. Page 19 at the top goes to the next one, which is Core 2.3C. The staff are knowledgeable of the practices and procedures relating to emergency preparedness responsibilities and emergent events. And they're saying staff members at all levels, that means field staff and office staff, demonstrate an awareness of their own responsibilities to ensure the safety of self and others. This is an important part in this particular presentation because surveyors really like to focus on you understanding what your responsibility is in the event of an emergency. So, in addition to patients at admission being assigned a risk level in the event of a disaster, each of you plays an important role in the management of an emergency and how we're going to care for our patients. When we add an employee, every employee anywhere, we immediately revise our emergency management telephone tree. That telephone tree is designed so that every employee has a role in assisting to keep our patients safe and at the same time keep each one of you safe. So the emergency management telephone tree that you have, that we update on a regular basis, says you have two responsibilities in the event of an emergency. You are to call the office and to let us know you're okay and if you can help or not. And you're to call the other people on your list on the emergency management telephone tree. We can't predict what the emergency will be, what part of our county may be affected, and who, whether patients or employees, will be affected. So the emergency management tree is designed in such a way that you get multiple phone calls, not just one. Because if one person were assigned and that person were part of the emergency and couldn't call you, couldn't get through to you, we wouldn't know if you were okay or not. So the tree is designed, and a surveyor wants to know that you understand that you have multiple responsibilities. If you're the nurse, you're calling your patients, and you're calling your patients based on that risk level that was assigned at admission. If they're a high-risk patient, we're calling them first. Average gets called after all the high-risk patients have been called, and low get called last. All patients are called. All staff members must call and report that you're safe and you can help or not, which simply means you're in a position in the county where you can get to patients. In the office personnel are tracking each employee calling in and saying, I can help, I'm in this part of the town, city or the county, I can't help, I'm actually on the part of California that's out floating in the water now, or whatever has happened, okay? So you use your emergency management telephone tree, and remember that's the document that stays with you at all times because you don't know when you're going to get the call. So I love it when I'm at a dinner or an engagement with some of you and I see in your purses or in your cars you have your emergency management telephone tree, because that tells me you get it. You know that right now on Sunday evening at 4:30 you could get a call from me or Wendy or Jody or Alicia or anyone else saying, we've had to initiate the emergency management tree, so start making your calls. And you have the sheet there with you and the phone roster so you know how to make those calls. Patients know that that's going to happen too as a result of signing that emergency management process form that they also have a copy of in their charts. The next one is C2.4a, coordination between the clinical services, financial, and operational components of the organization is evident. Surveyors are going to say to you, how do you as field staff know anything about the operations in the office or the financial situation people are in? And can you describe who collaborates on that information and what kind of support there is or organizational divisions? Well, when we have staff meetings monthly, IDG meetings every Wednesday, you know, a part of that includes our quality assessment performance improvement information, where we are financially, and what changes are happening operationally. With 2014, and this is being taped in the early April of 2014, we've already had multiple changes this calendar year. Just days ago, April 1st, there were more regulatory changes put into place, and there will be more effective July 1st and again in October. Everyone in the organization knows what's happening and how we're changing processes, forms, people's roles and responsibilities to meet those regs, because you're all involved in meetings, you all get written documents, you all review the policies and procedures, and that's how you know what's happening with operations, finances, whether you're in the field or you're in the office or you're a contracted employee. That is it for this section, and we covered a lot of stuff. This is an important section. This is one I guarantee surveyors are going to ask you about. So get familiar with your role in the emergency management plan and what to do and how you do it. I guarantee you that's a question you'll be asked by the surveyor. And know that we have a safety program for the patients as well as you. And one closing thought since we're in California. Usually, when a disaster strikes, in healthcare, the employee is trained and responsible to take care of the patient first. In a fire in a hospital, you get the patients evacuated. In California, earthquake safety says you take care of yourself first, because if you go down in the earthquake, you can't help anyone. So earthquakes happen quickly and are over, unlike fires and floods. So a surveyor in California specifically wants to know that you know if we have an earthquake, your first responsibility is your safety. Then you take care of the patient, all right? So be really smart. Blow a surveyor away like you do me every day. Thank you. My name is Donna Olson. I'm the administrator with Interim Healthcare, the Gift of Hospice, and this presentation is being prepared for you. I'm hoping that by watching these presentations, and this is number 3 in a series of those prepared for you, the staff, to be able to answer questions from the CHAP surveyor when they arrive any day now. So we are on page 19, and we are on the 3rd box, which is a core regulation, and that's a C2.5A. All protected health information or client records, hard copy or automated, are kept confidential and are safeguarded against loss of unauthorized use in accordance with policy, everybody's policy, not just our written policy from the P&P manual, policy and procedure manual, but also state, local, federal, Medicare, CHAP, all the regulatory body policies. So what the surveyor is looking for all of the staff, that means the people in the office too, not just the field staff and the contracted staff, to be able to describe or what we have in place, what are our policies, what are our protocols for guaranteeing patients' information is kept confidential. And that includes the use of the records you take with you and transport somewhere while you're traveling and while they're not in use. So I want to talk to you, all of you, office staff and clinical staff, about the number of ways that we protect client information. First of all, for you in the office, our computers actually have lockdown times. That's why we have to have passwords to be able to get into a screen. So the patient information that's available in the computer is only available by password. Additionally, our system is designed where a person in the office can only access the information they need to know to take care of their role in that patient's care. And I want to reiterate that phrase. Patients' health information should always and is always shared on a need-to-know basis. So therapies that aren't seeing our patients don't have access to patient information because they don't need it, okay? So the computer systems and who's allowed access into certain parts of our computer and the software that has patient information are one protocol. For the field staff, the report line that you're leaving patient information on, as you know, has a password that only the clinicians have available to them. And when an employee leaves our employ, or a volunteer no longer volunteers, we change the password. And we don't leave that information on the line, do we? You have to come in and get that information in person. That's another way we protect patients' health information. When you're transporting patients' information to patients' homes, you know we have the HIPAA box, which is an acronym for that Health Information Privacy Act, Accountability Act. You don't have to know what HIPAA stands for, HIPAA, but you definitely need to, but I know you do know what HIPAA is, and you definitely need to know that that's why this is your HIPAA box, and you all call it that. That's another way. Now see, these are obvious answers, but when you're under the microscope with a surveyor, sometimes the obvious disappears. So that's why I want to do this with you guys. So how do we protect patients' information? We keep everything in our HIPAA box. We use a spiral notebook that we track with us all day long, right? And what were each of you trained to do? Use only one side of that spiral notebook, so that when you pull up to a home, you flip your notebook over, there will never be another word of anything on the other side, so that if anybody looks in your window, they don't see patient information. That's another protocol for how we protect their information. At night, on the weekends, when you're not working, you are supposed to take your HIPAA box and your spiral notebook inside or lock them in the trunk of your car. We have protocols in place for a breach of information, and you have this information in your policy and procedure manuals. If someone were to steal your HIPAA box or your car when it was locked in the trunk, you must report it, and we begin immediately to go through what information was in there and what we need to do to protect our clients. So a surveyor needs to know that you know and that you're practicing, whether you're office or field staff, protection of patients' information, okay? The next one is, well, before I move on, the last component in C2.5A is that you're knowledgeable about the client's right to access their information or to release client information. So one more important piece of this regulatory thing. When we admit a patient, they sign a record release allowing us to share records and reports with the treatment team. That means the patient is giving us permission to talk with any physician they want on their team, to talk with our contracted employees, therapy, ambulance, nursing homes. They give us permission to share the treatment plan. So that's one way that they're able to access their information. Any information we have from any of the providers, they can request and we will provide copies for them. Important for you to know, every employee, if a patient asks us for a copy of their labs, if a patient asks us for a copy of doctor's home visit or anything else, they are legally able to obtain that, and we would be happy to make them that copy. They simply have to request it. Okay? Now we'll move to the next one, which is C2.5G, which says organizations with alternate sites ensure, and we're going to stop there. We don't need to go any further at all on that one because it's completely, totally not applicable to us. Because why? We don't have an alternate site. This is our only office. We service all of San Diego County, but when they talk about sites in Medicare and CHAP, they're talking about another office. For instance, all of you know, there's a home health agency that has an office upstairs and a second site in Escondido. Both are home health offices. They have a different license. That's an alternate site. We don't have an alternate site. When a surveyor attempts to trick you and says to you, well, tell me what your policy is about transporting records from one site to another, your answer is, well, it would be in the policy manual, but we don't need that policy because we don't have an alternate site. And ladies and gentlemen, our second office is not an alternate site. That office houses no programs. The bereavement program, the volunteer program, all of the patient records, all of the employee files, and all of our day-to-day activity happens in that office, which is Suite 110. Our second suite is a space, but not an alternate site. Okay? So let's move to the next one, C2.7K. A routine assessment is made of the client's living environment to identify and evaluate potential safety hazards related to the physical space as applicable. What they're basically asking you to be able to talk about with the surveyor is, how do we know and what do we do with our patients when we identify there are unsafe things in the setting, in the home, etc. We all have a responsibility to identify that. So For starters, when the nurse admits the patient, part of the 6-page assessment, and it is on page 2 of the assessment, is specifically a fall risk assessment that identifies anything that might be that might apply specifically to that patient that would cause them to be unsafe. And page 5 has a section called Safety and Environment, where specific potential environmental hazards are identified. And if there are in fact hazards identified, then the next component is for the staff, the admitting nurse, to address what we need to do differently to remove that possible accident from happening or prevent it from happening. So additionally, each time any of the staff visit, their documentation includes a section on safety. So on an ongoing basis, the patient's safety is addressed with each visit and how we could avoid having them get hurt in any way. And as a little side note but applicable, part of the quality assessment performance improvement plan is monitoring the falls and why they fell and the education to try to prevent that. That happens on an ongoing basis too. And one more, I think. The next one, which is C2.7N, the organization demonstrates compliance with its infection control policies and procedures. And this says, and it's important that as you're looking through this guide and as we're doing that you pay attention to the verbs that are in use. Where it says staff describe, that means in an interview they're going to ask you to be able to explain something. When it says demonstrate, it means you're going to do it for them in the patient's home. So this particular one where it says the staff demonstrates knowledge of and compliance with the infection control practice, how sick of Jody and I are you from hearing us talk about bag technique, hand washing technique? When you walk in the house, the first thing you do is wash your hands. That you place a barrier on the floor that you put your bag on so that you don't take germs from the floor back out to your car and on to the next person's house. That when you use equipment on a patient, before the equipment goes back in your bag, you are cleaning it according to policy. That's what you're going to demonstrate. And we hope you'll spend the time to watch one of the presentations in this series, which is in fact a demonstration of bag technique and hand washing. This particular regulation includes a lot more than bag technique. The infection control policies apply to patients as well. So you're practicing them, and in this particular one you're demonstrating them. In an overall big picture, you need to know and be able to tell a surveyor, as part of our QAPI, Quality Assessment Performance Improvement Program, we track all infections. You all hear us doing that every single IDG. Are there any infections we don't know about? I already know about so-and-so's urinary tract infection. I already know about so-and-so's respiratory tract infection. Are there any other infections? That's a part of our infection control policy too. And I think I will do one more in this short series, which is C2.8C, that staff are aware of organizational mechanisms for receiving and resolving complaints, because it's so perfect for what I just shared with you. What do I ask in IDG right after I ask, are there any infections I don't already know about? You're right. Are there any complaints we already have not discussed? That's what the surveyors are looking for. What do you do if a patient complains? You know, you're reporting it. We have a follow-up mechanism in place. Surveyor may say to you, well, what is a complaint? Your answer needs to be anything that a patient or their caregiver is not happy with. That may be that so-and-so calls right before they arrive and give a 2-hour window, which is what you're supposed to do, but they wish that you would come later in the window. If they say something like that, that's an opportunity for us to do a better job, you guys. So we want those complaints. A complaint is defined as anything we could do better that a patient or their family is willing to share with us, okay? So sometimes there's a personality clash. A family member may complain because they don't like that person's approach. I hope they tell us that. I know all of you hope that too, because that allows us a chance to send somebody else in there, and it matters for quality of care, and that's our main thing. So the surveyor needs to know that you know what to do with a complaint and what happens when we receive it. We do everything in our power to make it okay. If we as an agency cannot make it okay, if we cannot satisfy them, in the admission documentation and the red notebook that stays in their house is on the bottom of the patient rights, the client bill of rights sheet, are the phone numbers for both the state and for CHAP, so that if they're not happy with the care we provided, if we can't solve their complaint, they can report us and the complaint as far up as they want to go. And we review that information with them when we admit them. So that's it for this section, which included using your HIPAA box and your spiral notebook the right way to respect patients' privacy, being able to explain to a surveyor that if you're in the office, we have protocols in place to protect the information, that information is shared on a need-to-know basis, that we do not have an alternate site, that when you take your information home that has anything to do with patients, that you're taking it out of your car and locking it up, or you're locking it in your trunks, that you'll report that it's lost or you think somebody else has accessed it as soon as that happens, that we have a safety assessment in place when we admit the patient, and it is assessed on each visit and shared as a part of the care plan, that there's an infection control plan in place that monitors your practice for preventing infections, and that monitors the presence of infections or the development of those, and that we address those on a regular basis, as well as the complaints. And a complaint is anything the patient or the caregiver wants to share with us that allows us to do a better job. So I know you know the answers to all those questions, and don't hesitate to let the surveyor know that we so rarely get a complaint that our complaint log doesn't stay very full. See you on the next one. Hi you guys, good to see you again. We are starting a new section, so this is the section that is starting on page 20 of your interview guide. We're in the core regulatory body of CHAP. We're starting with C3.1b, where you guys are employed and assigned responsibilities commensurate with your education and experience. Surveyor plans to interview you, and in addition to interviewing you, they're going to watch you at a visit to see that you are following your own discipline-specific practice standards, and that we have not overstaffed you for areas of responsibility that you can't keep. So, what I want to talk with you about in that section in particular is that in addition to your titles and your job descriptions, we do the competency checks upon hire and annually, so that you can tell that, so that we can tell that we're not sending you somewhere where you're not comfortable doing tasks and completing responsibilities that you haven't done before. So how that translates is, if you've never done an enema before, then we wouldn't send you to do an enema. Instead, we would see on your competency check that you're not comfortable with that skill by yourself. So we would send you along with a nurse who is very comfortable and has years of experience doing that, and she could teach you and show you, and then maybe the next time you went, you could do it with a nurse, and then maybe the third time you'd feel comfortable doing it yourself. We are assured that you're following your standards by doing supervisory visits. So C3.1C then says that there's a job description for each of you and who you report to, what your duties are, and that you have the education and the experience specific to the position. The surveyor is looking for you to confirm a clear understanding of your responsibility and the lines of authority. Lines of authority is referring to your org chart, of which you all have a copy of the org chart that has just the titles and the names of the disciplines, and you also have a copy of the organizational chart that has all of your names on it that show who you're responsible to report to. So what the surveyor is wanting you to say is, I know my supervisor is, and if I need help with a skill, I know to ask for help and they will teach me. C3.1F is personnel policies and conditions of employment are provided to employees at the time of hire and thereafter as updates and revisions are needed. So the surveyor needs to know, and each of you have this, that when you became employed, you got a copy of your job description. And I know you all did because I do that with you. So as soon as you sign it, I write, employee has own copy, and I make a copy right then, so you guys all have that. Your conditions of employment go along with that. And each of you got a 3-ring binder that has in it copies of some of those policies and procedures from the great big policy and procedure manual we already discussed, but it also starts with your employee handbook. You have an employee handbook from OASIS that's specific to their employment stuff related to payroll and your checks. You also have an employee handbook in your 3-ring binder that's specific to integrity and compliance and the conditions of employment. So those are the ways that you can demonstrate to a surveyor when the surveyor says to you, tell me what you know about your conditions of employment. And I think if a surveyor just said that to somebody, I could see some of your faces just looking at the surveyor like, huh, conditions of employment. Well, you know, the conditions of employment are that you have current licenses or current certifications, that you complete your competency checkoff list, that you demonstrate your competencies in areas that need demonstration, that you're willing to learn, and the process for obtaining personnel-related information is simply that you have a personnel file here in the office, and you're welcome to what's in it. We hand it, you know, you get copies of your evaluation. I offer to make copies for people who don't even say they don't even want one. So the next one is C3.1J. An annual performance evaluation process is in place, and the employee needs to participate by planning or setting new goals and having a response to the evaluation. You do all have a performance evaluation, more than annually, I might add. Our policy is no less than annual. Every employee I have has had a probationary evaluation, so all of you know that at 3 months, some of you at 4 or 5, waiting for you to get a really good grasp on your role, had an evaluation. Everybody has an annual evaluation. There are 2 different forms. If you're field staff, you're used to the 1-page performance evaluation that's specific to you following infection control, respecting patients' rights and responsibilities, etc. If you are office staff, then we have a non-exempt employee form that's more specific to the categories of work that you do in the office. The volume of work you have, your attention to detail, your use of the computers, etc. So all employees, whether field, technical, office, receive a probationary evaluation and no less than an annual evaluation. Several of you have had more than an annual evaluation. If you've changed roles, you've also had another evaluation 3 months into that role. Okay? And you will remember me saying every time you have to write at least 2 goals on there. Now you know why every time I say to you, you have to write at least 2 goals on there, because it's a requirement. You can't just go, oh, that's a great eval, thanks for the raise, and sign your name. You have to write 2 goals you're going to work on. And you remember that I take you back to the goals you wrote the last one. Remember, I have a copy of it and say, so how do you think you did on this goal? Well, I actually think you achieved that. So, goal setting. C3.1L, the organization shall provide in-service and staff development as needed and required according to national professional standards. The surveyor wants to know that you're getting in-service education. So how many different ways do you get that? Let's see. You get education from multiple people at every IDG staff meeting. We have guest speakers that come in every month. We have the Learning Center, which is your intranet, which I remind you twice a month. You should do 2 hours of continuing education learning on the Learning Center. Not only does it give you the continuing education, but it's paid time that you can do on your own schedule. We have you take tests when you come to work. In the homemakers, hospice aides, the LVNs, the RNs, you take tests. And if you didn't do well on the test, we give you specific Learning Center classes to improve that. So there are posted annually calendars for the in-services. Every year we post those calendars, and monthly we do the in-service topic that's on it. There's a general in-service calendar and even a hospice aid specific calendar. If you're a hospice aide, you know that part of your education comes from the monthly Hospice Aid Digest, in which you get CEUs for taking those tests, and we discuss those in your monthly meetings. So the surveyor is looking for you to tell them how you get ongoing education and what kind of in-services are available to you. And finally, the last core question there, Section 4.1a, current budgetary, business, and marketing activities are integrated into the process. Staff describe the planning process for meeting business and marketing activities. That one is specifically to our community education program, and you should be able to tell the surveyor we have a community education program where both Donna and Matt are going to nursing homes, churches, mobile home parks, anywhere where we can tell people about the wonderful service that hospice is and how it's free and how it's so misunderstood. That community education program is wrapped into our budget, and you guys know about the budget because it's something that I share with you on an ongoing basis, where we are, what monies were held with ADRs, etc. So the answer is, in our IDG meetings and in our staff meetings, all of us are privileged to that information. So that's it for the core section. That wraps up most of the section that's specific to personnel. You will remember in summary that when you come to work, you fill out a checklist based on how you feel your competency level is for the skills. Every single position has a checklist, a competency checklist, including volunteers. That you have a job description that's specific to your role, no matter what your job, and even volunteers have a job description, which sounds like a dichotomy, but you know, in hospice, volunteers are treated just like employees. And that annually you're reviewed as to your performance on it, no less than annually, and you participate in that by setting new goals, and I participate in that by helping you achieve them and giving you the tools and resources to get there. So that's it for that section, you guys, and I'll see you on the next one. So we're on page 20 of your interview guide, about 3/4 of the way down, where the first H is, and that's H1.1a, the staff can verbalize the mission statement of hospice. Come on, you guys, you know, it's patient, family, empowered care, preserving dignity. You know that, and providing comfort. I bet you the majority of you watching this can say it, maybe not word for word in order, but I bet every one of you know what it's made of because I hear you saying it and I see you practicing it every day. Our patients get it first page in their Red Star Care notebook. It's on the back of all of your business cards, and you all have business cards. If you're out of them and you need them, let me know. Our mission statement's on the back of that card. We review that every 3 years and see if we are living by it. Is it still good enough? Is it what we want to do? Do we want to change it? And we just did that revision last December. So it remains that was our initial mission, and we're proud to practice it for 3 years. So That hasn't changed any, and I'm grateful to each of you for letting our patients and family guide their own care. The next one is to describe how we support that mission, and I should have read that first before I just blabbed on about how you let our patients and their families tell us. And some specific examples for a surveyor may be, well, for instance, when a surveyor says, well, give me an example of a time when you adhered to your mission. And our list is endless. The times when patients' families say, she's running a temperature, but I really don't want to go through antibiotics anymore. Or she's having chest pain and we gave the 3 nitro, but she's still having chest pain and we don't want to take her to the hospital anymore, even just for an ER visit. When our families say, well, I know it would be better for my back taking care of mom if she was in a hospital bed, but she really wants to be on the couch. Where do we leave her? On the couch. Patient family empowered care. As long as we can safely deliver the agreed upon plan of care that the family and the patient have participated in and set forth, then we let them be in charge. After all, they're not in charge of anything else, and you know how painful that is. H1.2D, number 4, IDG members describe the process and documentation used to monitor services and validate care compliance at all locations. So, at all locations is the key phrase in here, and this is one of those really important ones, you guys. I need to get your attention on this one. I promise you, a surveyor is going to ask you specifically about this, because what she or he is seeking out is that you know, every one of you know, when we have a patient who moves to, lives in, or in any way ends up in, even if it's for 5 days of respite, a facility, that we're still in charge of the patient and the care plan. The facility is not. That means that when we take a patient to a nursing home, when they move there, when they go there on respite, we, the hospice team, still guide the care plan. So we can't actually put a patient in a nursing home where they won't allow 24-hour visitation, because the hospice philosophy is that family and loved ones can visit whenever they want. So our contracts are with facilities that abide by and recognize and respect our philosophy of delivering hospice care. So the surveyor wants you to be able to say and know, it doesn't matter where they go, we're still in charge of the care plan. The nurse at the nursing home may want a different pain medicine. She can talk to us about it, and we might even be able to do that if we think that's necessary, but we're in charge of the care plan. We're in charge of what medicines are given. We're in charge of whether the patient gets a shower or stays in bed or gets up or goes to the dining room to eat or anything else. So that at all locations is telling you, you need to know that we, the IDG team members, are always monitoring the services that other people are giving, and those services are following the care plan. The last one on page 20, 2F, 2G, 2H, IDG members verbalize their roles and contribution to team conferences. Verbalize their roles and contribution to team conferences. You know I don't need to say anything else, right? IDG. Okay. Next page. Hospice, section 1.5a, staff confirm that policies accurately reflect staff practice and staff describes interventions. They're not going to ask any questions about this. They just want to know that you are following the policy and procedure manual. We've already gone through that in the past. You have your own 3-ring binders that have big components from the great big policy manual in it for you, so that your everyday policies and procedures, guidances are right there for you as a resource. They just want to know that you know where to go to find a policy and that your interventions are following policy. So if you, in the presentation prior to this one, I used an enema as an example. So let's go back there. If you're the nurse who's never done an enema, and one of your patients actually has reached a point where that's been ordered by the physician, because of course you have to have a physician's order, before you head out, even with the nurse who's going to demonstrate it to you, the first thing you do is go to the policy manual. You go to the Lippincott manual and you look up the policy for giving an enema. What kind of enema is it? Is it a Fleet's enema? Is it a soap suds enema? Whatever type of enema it is, you look that up, review that policy, because that's the way you're going to give it. Okay? Clinical staff verbalize understanding of pain control measures and progress toward controlling pain. And that will be the end of this section, and let's talk just for a few minutes about pain control and progress, although we have talked about it before. Our policy is that a pain assessment is done on every visit by every discipline, just as you do a board score. So either you put a number for the pain scale from 0 to 10, with 10 being the worst, or if the patient's unable to give you a number, you use what you know is called the PAINAD scale, P-A-I-N-A-D, PAINAD. I started to write it on the board, but I'm not going to. I feel like that would insult you. You know, if a patient can tell you their pain level, you put the number. If they can't, you use the PAINAD scale, and based on that scale, you put your number. Just like the board score for shortness of breath. If a patient's pain level is 3 or greater, we have to follow up within 24 hours to be sure that it is not increasing and that whatever pain medication we ordered is effective. When anyone has a pain of 1 or more, we have to do a more thorough pain assessment. So if somebody says their pain level is 2, that's a cue that then you have to talk about what brought the pain on, describe the pain, tell me about the pain in your own words. What's the quality of the pain? That's when you're looking for them to say things like it's crushing, it's sharp, it's burning, it's intermittent, it's constant, it only hurts when I do this. Their complete description of the pain. What makes the pain worse? When I move this way, if I position this way, if I take a deep breath, when I drink cold, when I lay on my right side, what makes the pain better? A complete pain assessment. That's our specialty. You know that, you guys. So a surveyor wants to know that you get that. If somebody has pain, you don't just order the pain medicine. You explore what kind of pain. What's our best treatment for it? What's worked? Have you had this pain in the past? What's worked in the past for pain control? So the policy is if somebody's pain level is 3 or greater, we have to follow up the next day, okay? And you have the pain policies and you do the documentation on a regular basis. So that's it for this section. The next section will be about psychosocial assessment. Thank you, guys. Hi, welcome back. I'm so grateful you're watching all of these. This is the last of this section, and I see by what's remaining on your interview guide the rest of page 22, 23, and 24. We have in prior presentations discussed most of this, so I'll move kind of quickly through this. There are just a few new ones here. So let's start mid-page, where staff is again all by itself in that first column, and we are under the hospice section, H2.4C, and then 4C 1 to 3. The surveyor is looking to know that the RN did a comprehensive assessment. You've heard us talk about that. They do a 6-page comprehensive assessment when they first admit the patient, and we do our comprehensive assessments usually as the very first initial visit. The regulation allows us 5 days to finish it, but our policy, as you know, is to do it the day we're there. Every once in a while, if we admit somebody on a Friday, the comprehensive assessment isn't finished till Monday, but that's a rare moment. So the RN is the only person who can do the assessment, and she does that 6-page assessment at start of care. Moving to the next one, IDG members describe the process for integrating those elements into a performance appraisal program An example of using aggregated data to improve a problem. Well, if you read that carefully, you know that section, point 4C, point 3C, is talking about QAPI. What does QAPI stand for? Almost. Yes. Yes. Quality Assessment Performance Improvement. And think that through. We assess the quality of what we're doing. We do that for the purpose of improving our performance. Okay? QAPI. This particular regulation is expecting every one of you to be able to understand how we are doing that. You know, in every IDG we discuss QAPI. I will discuss more of this in a specific presentation that I'm going to do for you on QAPI. So suffice to say right now for that one, we record falls, we keep track of our infections, we count those numbers, and then we apply training appropriately. That's one example of how you do that. Next one, 4E, the staff can verbalize recognition of case coordination responsibilities and assignment practices, and the nurse can describe the responsibilities. We have assignments done a few ways here, don't we? You have a geography, you're partnered with each other, you are given assignments based on what your competency testing showed, and you have job descriptions that describe your responsibilities. The next one, hospice staff can identify referral and transfer procedures and give examples. So transfer procedures can be transfers to a facility, or they could be transfers to another level of care, can't they? Because we have 4 levels of care. So if we're transferring somebody from home to a facility for 5 days for respite, the family initiates that. We identify the place. We have our own ambulance service that we contract with to actually physically transfer somebody. You have policies that guide you for when they meet criteria to change to a different level. Who coordinates all that? The whole team. The case manager's in charge of it. Our medical director is obviously giving the orders, and all of us talk about those kinds of things at IDG as well as on the IDG line. The next one, H2.4F, IDG members demonstrate verbalized IDG participation in problem solving using assessed needs and actionable outcomes to develop and revise the care plan, and that you're able to verbalize your role and your contribution to team conferences. No, don't turn off your video. I'm not going to say anything else. Staff describes and complies with med administration and attempts to get the necessary drugs, biologics, equipment, supplies, etc. We've already talked about that. The RN makes the assessment, orders the supplies, the equipment, the drugs. We pay for it. As more things surface as being needed, they're ordered. Anyone on the team can tell the nurse case manager, I think we need this, and we take care of it. H2.5H, describing all the different laws about the Nurse Practice Act, the DEA, as far as safeguarding controlled substances in the home. We have all kinds of controlled substances in the home, and if we think there's a problem with drug diversion, then we solve that with a few different mechanisms. Sometimes we change the route of delivery of medication so it's not as attractive to somebody it's not prescribed for. Sometimes we change the medication itself. So we have forms where we could document the amount of medications left, and when a patient expires, there are directions left in the red notebook for disposing of those medicines. The next one, 5G, 5J, is about getting supplies again, appliances, drugs, etc., related to the terminal diagnosis. We do provide the equipment necessary, whatever drugs are necessary, etc., and we pay for them. Next one, which says the staff understands and provides examples of appropriate use of emergency and do not resuscitate protocols. If a patient's a DNR, then you know we don't call 911. If they are a do resuscitate and you're certified, you start CPR. That is a part of your orientation. You have those policies in there. And it's a great policy in Chapter 6 on page 36, the medical emergency response, which is really thorough in describing if the patient is a DNR but the daughter wants you to resuscitate, all the different circumstances that can happen. Okay, so, but it's not that complicated. If they do want to be resuscitated and we don't have an order otherwise, we would resuscitate them and call 911. If they do not want to be resuscitated and we have a DNR in place, then we don't call 911, and we keep them and the family as comfortable as we can. We have policies to support those decisions. 5M, methods for dealing with ethical issues. We did a whole component on having an ethics committee and who was in it, etc. 11E, the next one, practice and procedure relating to referring victims for abuse and neglect. You remember that a part of what's in the Start of Care packet is about abuse and neglect, and because we're mandated reporters, we have to report what we think may be abuse or neglect, and you have those policies and those descriptions in your binders. So Addendum A in Chapter 5 in your policy manual is a review of that abuse and neglect information. 1D, 1 to 3, paraprofessionals can describe their training course. They're talking about, when they say paraprofessionals, they're talking about either our homemakers or our hospice aides. And your training class actually happened before you came here because you got your certificate. And we don't offer our own training class in hospice. We do our own orientation for you. So that's the next section, which is the end of page 23 and the top of 24. Competency testing. And I want to partner that with the very next one, which says staff can describe their orientation to new responsibilities and patient needs when assigned to a new job classification or assignment. This is really a key point for all of you to remember. What they are expecting us to do and what we are doing is, when an aide comes to work for us, we check your competency before you give care to a patient. So we want to know that you know and see that you know how to do a shower safely, a bath safely, range of motion exercises, all the personal care things we would assign. So you do your competency checks, you take your test, we do an orientation to the patient and the care of the patient, and we send you out with another aide who checks your competencies too, okay? For the rest of you, same thing, except for we usually don't go with every nurse for a supervisory visit from the get-go. You do your competency checks, you go out with other nurses, then after you're practicing, the supervisors go back out regularly and do supervisory visits for you. You don't accept an assignment where there's something that you haven't done before. Instead, you speak up and say, I want to learn how to do that. And then we teach you how to do it. Okay? Next one, 1M, ongoing training, continuing education. Oh my. Yeah. And the next one, I mean, you really don't need me to go back through the Learning Center and all the notebooks and all that stuff, right? Staff can describe emotional support measures available and their effectiveness. I won't comment on that one. That we've tried several different things to remember, to be able to do a memorial service that's important for us in celebrating what we've done for people. And we're continuing to experiment with what helps you guys feel the best. We have such loss. And some people don't like the term, but the term is used, and it is a common term to hospice professionals, and that's compassion fatigue, which is that the ongoing pile of loss and grief and pain that we all carry as a result of being close to our patients and losing them and being close to our family members. Takes its toll on us. It's why you hear me say all the time, take care of yourselves. It's why I implemented the health improvement program for all of us, for all of you. So what we have in place now is, as you know, we have 2 chaplains that I encourage on a regular basis all of you to talk to about how you're feeling and the things you're struggling with. And those are confidential discussions that I know nothing about. Anyone's welcome to talk to me about the Employee Assistance Program, which is completely anonymous for talking to somebody professional outside the organization. And we try to do fun things to help all of us have a good time, and that's why we do celebrations like, dinner for you and your loved ones, which we've done now in North County, bowling party that we did out in East County, celebration at our 2-year anniversary at Dick's Last Resort. I try to offer those things to all of you to help all of us maintain our sanity while we keep giving so much. But the main thing that I want you to know is if you feel like you're not getting the emotional support you need, please tell me and say something so that we can do that. And so I would hope that you have no problem telling the surveyor how we help support you in your emotional losses. And if you think you would have trouble telling a surveyor that, please come and see me, please. Techniques for identifying a need for change in the level of service goes right back to the RN case manager recognizing we can't, if we can't keep them comfortable at home intermittent, we would move them to the level of care called continuous care where they stay at home. If we can't take care of them at home and meet their needs, we would move them to GIP for short-term inpatient, general inpatient care. And finally, how collected data is utilized at a functional level. That collected data takes us back to the QAPI. So don't forget, be sure and watch the next one, which will be a QAPI introduction for all of you on how to talk with the surveyor about your role in QAPI and how we apply it every day to improve our performance. Thanks, you guys. See you later.